Hello, everyone. I'm Dr. Soumya Chatterjee. I'm a rheumatologist at Cleveland Clinic in Cleveland, Ohio, where I direct the Scleroderma program. So I'm honored to be here today. I thank the National Scleroderma Foundation for inviting me to speak and for organizing such an excellent program over the last few days. It is a pleasure to be with you all today. I hope there will be time for questions at the end of this talk. So you are welcome to write them down and we can get to them later on. So let's get started. So my task is to discuss understanding scleroderma tests and how to understand your results. These are my disclosures. I do not have any financial disclosures that are relevant to this talk. So the objectives of today's talk will be to understand the various bedside clinical evaluations that are required to confirm the diagnosis and type of systemic sclerosis or scleroderma. I'm not sure this was discussed so far by any other speakers. So this, I think, is important and is also part of the tests that are necessary, clinical evaluation at the bedside. So one of them is clinical assessment of extent and severity of skin tightness, which is measured by this modified Rodnan skin score, in short MRSS. And the other one is Nailfold capillaroscopy, where you're looking at the cuticle under the microscope, the cuticle of the nail under the microscope, to differentiate primary Raynaud phenomenon from secondary Raynaud's phenomenon and predict the different patterns of disease. And we will discuss this in the next few slides. Then we are going to discuss the various scleroderma tests that will include laboratory tests, testing for various autoantibodies, which I'm sure you have heard about in the last 2 days, the speakers from the last 2 days. We will discuss briefly high-resolution CT scan of the lungs, which is the test of choice to evaluate for interstitial lung disease in systemic sclerosis. And again, you had excellent speakers who have already discussed this. Pulmonary function tests will be discussed after that. We will talk about an echocardiogram, a 2D echocardiogram, that is to screen for pulmonary hypertension, 6-minute walk test, and then we are going to talk about right heart catheterization, which is the way to confirm the diagnosis of pulmonary hypertension in selected patients, and then various gastrointestinal investigations that I will try to touch upon briefly. Hopefully, I'll have time for questions at the end. So what is systemic sclerosis? It is an autoimmune rheumatic disease of unclear cause that is characterized by progressive skin thickening and tightening. There's narrowing of the small blood vessels. So it's a disease of the small blood vessels, and it's not inflammation, just narrowing from fibrosis of these blood vessels. We have variable degrees of internal organ involvement that determine the prognosis in patients with systemic sclerosis, and it varies from patient to patient. And then we have immunologic abnormalities that are characterized by the presence of certain autoantibodies. So what are the clinical manifestations of systemic sclerosis? So on this slide, we're going to talk about all the common manifestations that are seen. And the next slide will be discussing the early manifestations of scleroderma. So the various organ system manifestations of scleroderma, often patients present with Raynaud's phenomenon as the first symptom, which is a result of inadequate blood supply to the fingers. And sometimes it's severe enough to present with digital ulcers or ulcers on the fingertips and sometimes the toes. Skin involvement can be in the form of swelling or puffiness of the fingers and hands in the beginning. And over time, there is tightening of the skin. There's pigmentary changes, both hyper and hypopigmentation, which means darkening of skin or lightening of skin. And sometimes they're next to each other, called salt and pepper skin. Calcium deposits, calcinosis, telangiectasias, which are dilated capillaries in the skin. And itching is an important symptom of scleroderma called pruritus, which could be a sign of active inflammation of the skin. Lung involvement can be in the form of interstitial lung disease and pulmonary hypertension. There are other causes of shortness of breath, as you heard about yesterday, but also these are the two main causes of shortness of breath in patients with scleroderma, both interstitial lung disease and pulmonary hypertension. Gastrointestinal involvement, there was an excellent talk from Dr. Walkman yesterday discussing all the different gastrointestinal complications of scleroderma. Kidney disease, scleroderma renal crisis is another serious complication that tends to happen early in the course of the disease. Sjogren's syndrome, which is a manifestation where patients present with dry eyes, dry mouth, and dental problems. And you heard a talk yesterday from Dr. From our dentists. The two dentists gave an excellent talk on that. Muscle disease, which is muscle inflammation or muscle fibrosis. Joint disease, which could be in the form of joint inflammation, contractures. Heart can be affected in scleroderma sometimes. It's called scleroderma cardiomyopathy. Erectile dysfunction is another area that is often not discussed, but it's a common manifestation in men with systemic sclerosis. Patients often do not bring it up, so it's our responsibility as a rheumatologist to bring up that topic in men with scleroderma. So the early signs of scleroderma, as I said earlier, would be Raynaud phenomenon, which is the fingers change color on cold exposure, turning white or purple on cold exposure. And then swelling, puffiness of fingers, hands, and feet is an early manifestation. Skin tightening, thickening, hardening. There are different terms that are used, which could be followed by progressive tightening of skin that moves from the fingers to hands to forearms, and in diffuse patients to upper arms, and eventually the trunk can be affected. Similarly, feet, legs, and thighs can be affected. Acid reflux disease, heartburn, swallowing symptoms, swallowing problems could be seen in early disease. Fatigue is an early manifestation, and it could have multiple causes. Just inflammation is a cause, and anemia is a cause. Sometimes patients have underlying thyroid disease, which can also cause fatigue. Ulceration of fingertips and toes, sometimes that could be the presenting symptom. Or it could be in somebody who has had Raynaud's for many years, now presenting with fingertip or a toe ulceration. Shortness of breath on exertion is less common as the first manifestation of this disease. Similarly, a dry cough, which is a result of interstitial lung disease, as a first manifestation is less common. So it's important to realize that scleroderma is a multi-system disease with extremely rare condition. So it would be to the best interest of the patient to be referred to a specialized scleroderma center for evaluation and management. The primary care provider and rheumatologist in the community may not have enough experience to take care of scleroderma patients. They may or may not have seen one or two patients in their lifetime. So it would be best for the patient to be referred to a scleroderma specialized center. So the initial evaluation. So who are the doctors who need to get involved in the care of these patients? It's, as I said earlier, a multidisciplinary approach. Along with the primary care provider, other doctors who need to get involved. It depends on the clinical manifestations and the problems that develop. So rheumatologist is usually the quarterback, somebody who has a special interest and expertise in scleroderma. Such a rheumatologist will be the first point of contact in the hospital. And then sometimes we involve the lung doctors. If there is involvement of the lungs, we need to get a pulmonologist involved, either for interstitial lung disease or pulmonary hypertension. A cardiologist can be, their expertise is necessary if a patient needs a right heart catheterization to establish a diagnosis of pulmonary hypertension, or for scleroderma cardiomyopathy as well. Gastroenterologists, very commonly patients have upper gastrointestinal symptoms, and it would be important for these patients to get evaluated by a gastroenterologist with a special interest and expertise in systemic sclerosis. And less commonly, a nephrologist gets involved, which is a kidney specialist, when somebody presents with renal crisis. Less commonly, dermatomyositis and plastic surgeons can be necessary with ischemic ulcers or contractures, or patients who are interested in light therapy for their extensive skin tightness. These other experts can also get involved. So types of systemic sclerosis, there are main two subsets, which you already heard about. The limited form, where the skin tightness is confined to the fingers, hands, forearms, feet, and legs, but never move above the elbows, never move above the knees, and will not affect the trunk. So it's called limited scleroderma. It used to be called CREST syndrome, which is a short form for calcinosis, Raynaud phenomenon, esophageal dysmotility, sclerodactyly, and telangiectasias. Now we call it limited disease because patients do not need to have all the 5 letters and they behave the same way. And then there is a subset of patients who are called systemic sclerosis, cine scleroderma. So these patients where there is no skin tightness whatsoever, not even involving the fingers and the hands and the forearms, but they behave similar to patients with limited scleroderma. So they are called cine sclerosis. Cine means without. So that's a limited subset. And then less commonly, about 1/3 of the time, patients will have diffuse scleroderma, where the skin tightness moves above the elbows, above the knees, and affects the trunk. So the whole body can be affected in this subset. As you have noticed, both the limited and the diffuse patients do get involvement of the face. So the skin tightness is more widespread, and the time lag between Raynaud phenomenon, which is often the first symptom, and the first non-Raynaud manifestation is a whole lot shorter in patients with diffuse scleroderma as opposed to limited. In limited patients, the Raynaud can be the only manifestation for many years with some puffy fingers, but over time, other manifestations appear. Whereas in diffuse patients, this time lag is much, much shorter. So the skin tightness progresses above the elbows, above the knees. There's more rapid rate of progression and more severe internal organ involvement. There's high risk of acute kidney failure, which is called scleroderma renal crisis. And this is almost not seen in patients with limited scleroderma. And there's high risk of progressive pulmonary fibrosis with certain antibodies, and also major gastrointestinal involvement causing malabsorption. So at the bedside, what we do a bedside evaluation of skin thickening. So as you can see, there's a hand on the left side which has a normal skin thickening. That means there is you are able to pinch the skin between the thumb and the index finger. There is no skin tightness at all. And on the right side, the back of the hand is hard to be pinched because of the tethering and tightness of skin. So that is something you see in scleroderma. So at the bedside, what we are supposed to be doing when we see a patient with scleroderma is this, the skin scoring, which is looking at 70 different areas of the body: fingers, hands, forearms, arms, feet, legs, and thighs in pairs, because we have the left and the right, and then face, chest, and abdomen. Total 17 areas. And each of these areas, we use our thumb and index finger to pinch the skin. And when the skin is not at all involved, then the score is 0. So it's called modified Rodnan skin score. And the score is 0 when the skin is not affected. You can generate fine wrinkles by squeezing the skin between the thumb and the index finger. No thickness is appreciated. In mild skin thickness, easily able to detect a thickened skin fold, you are able to generate a skin fold, but it's thickened. It's not normal. That's where the skin score is 1, and that is mild skin thickness or tightness. Then comes moderate skin thickness or tightness, where there is difficulty in making a skin fold and unable to appreciate fine wrinkles anymore. You are able to pinch the skin, but with significant difficulty. And that's the score of 2. And then we have severe skin thickness, where there's inability to make skin folds at all. Between the 2 fingers, you can use, as you see in the figure, the skin cannot be pinched at all. So this is where the skin score is 3. So we are looking at all these different areas of the body in this patient: fingers, hands, forearms, arms, face, chest, abdomen, thighs, legs, and feet. Total 17 areas. So the denominator in each of these areas, we palpate and get a skin score, add it all up on this score sheet, and get a total score. The denominator, which is the maximum possible score, is 17 times 3, which is 51. And this particular patient has a skin score of 25 based on each of these areas and the sum total that is put on the left side. So the skin score tends to progress in patients with diffuse disease over the first 3 to 5 years. The skin score progressively goes up. As you can see here, the skin thickness, which is on the y-axis here, the skin score is going up. It reaches a steady state after that, after the first 3 to 5 years. And this is with or without any treatment. And then it starts softening up in the opposite direction. So when the skin gets tighter, it moves from fingers to hands, forearms, arms, face, and face can be affected, but it moves from fingers to upper arms, and then similarly from feet to thighs as time goes by. And when the skin softens, it happens in the opposite direction. So the trunk softens up first, and then the upper arms and thighs, and eventually the forearms and the legs and fingers and feet in the opposite direction. So the skin score goes down over time, as you can see, and this is 5 years, 10 years, 20 years after onset of disease. In limited patients who have skin score that is just confined, skin involvement that is just confined to the fingers, hands, forearms, and feet and legs, the skin score never goes up that high because they do not have truncal involvement or involvement of the upper arms or thighs. And then most of the complications that happen in patients with scleroderma tends to happen when the skin score is the highest. And that's when, there's a reflection of the amount of fibrosis in the dermis, which is the deeper layer of the skin, that tends to correlate with the skin score, which in turn tends to correlate with the amount of skin fibrosis of the internal organs. In patients with limited disease, the two exceptions are pulmonary hypertension and major malabsorption. These can not necessarily correlate with the skin tightness and can happen as independent processes because of various explanations that you heard about yesterday. But this is more of a small vessel disease manifestation, the pulmonary hypertension, and do not necessarily correlate with the amount of skin fibrosis. So the 3 phases of disease in scleroderma: for the first 6 to 12 months, there is swelling and of the fingers, hands, forearms. So that's the edematous phase or the swollen phase of the disease. As time goes on, this swollen phase is replaced by the fibrotic or indurative phase, where the skin gets tight and tethered. It's not puffy anymore, it's more tight. Then over time, the skin starts softening. And so this fibrotic phase can go on for 1 to 4 years. And then the skin starts softening, and that phase can continue for the rest of the patient's life. There are exceptions, but this is what tends to happen to most patients who do not, once the skin starts softening, it continues to soften for most patients. So this is the puffy hands in the early phase of the disease. And this is the more late phase of the disease, where you have contractures, skin tightness, tethering, and also these ulcers that are appearing over the knuckles. The other best bedside finding is called Nailfold capillaroscopy. So the capillaries at the cuticle, which is, as you can see here, this is the nail, that's the cuticle, these are the blood vessels. So you can see that the capillaries are prominent. Sometimes you don't need a capillaroscope, but if you were to do a capillaroscopy, this is the area that we're interested in. So you can look at this area with a pocket ophthalmoscope, with a capillaroscope. In our department, we have a big microscope, and the patient puts the finger underneath that microscope with a drop of oil at the cuticle, and you can see the blood vessels in the capillaries between the nail and the skin. And these are all normally parallel to each other like hairpin bends. And in patients with scleroderma, you start getting these dilated capillary loops, which are bigger than these, and they are of different sizes, and they're areas of missing capillaries called dropouts. So this is something you would see in normal patients. The capillaroscopic findings are shown on the left side. The blood vessels are thin, uniform, evenly spaced, and symmetric in distribution. They have a hairpin appearance. Minor abnormalities here and there can be seen, but you do not expect to see any major bleeding or capillary-free areas called dropouts. And the same findings are also seen in patients with primary Raynaud phenomenon, which is Raynaud without any associated underlying autoimmune rheumatologic disease. And patients often come to see us with Raynaud phenomenon as the only manifestation. And we want to figure out, is this primary Raynaud's or secondary Raynaud's? So in normal patients and patients with primary Raynaud's, the blood vessels all look normal, as you can see here. In scleroderma, there are phases of it. The early phase is called, this is the early pattern. After the onset of disease, you start seeing these giant capillaries. Few capillary bleedings can be seen, small hemorrhages, but no loss of capillaries or dropouts are seen, and preserved capillary distribution. This phase is followed by the active phase, which is where you start seeing giant capillaries, but also frequent small hemorrhages, as you can see here, moderate loss of capillaries, and mild disorganizations of the capillary architecture. And in the late phase of the disease, you see giant capillaries and hemorrhages are nearly absent now. So these giant capillaries that you see here and here are not seen. Severe loss of capillaries, which is called dropouts, and small capillary branching and sub-branching, as you can see here, which is called ramification due to tiny new vessel formation or angiogenesis and disorganized capillaries. So these are the three phases. So those are the two bedside evaluations that we talked about. And then we are going to talk about the initial laboratory tests that are important. Any scleroderma patient needs to get a complete blood count, which is white blood cell count, hemoglobin, and platelets, and differential count on the white blood cell count. So that's the first test that is routinely required. Complete metabolic panel that evaluates kidney function, where we look at the creatinine, electrolytes like sodium, potassium, calcium, liver function, which is albumin, ALT, AST, alkaline phosphatase. So these are all routinely done. Urine analysis, looking for presence of protein and or blood in the urine. A creatine kinase is a muscle enzyme. So when there is muscle inflammation or muscle damage, which is sometimes seen in scleroderma, you have elevated of the creatine kinase or CK. Autoantibody tests, which we are going to talk about later. Anti-nuclear antibody is the first test to order when we are ordering tests. In patients who are presenting with Raynaud's, the one test to order to differentiate primary from secondary Raynaud phenomenon is an ANA test. And then the scleroderma specific antibodies, which we'll discuss later, SCL70, anti-centromere, RNA polymerase 3, and these are also in the panel called the ENA panel that can sometimes be associated with scleroderma, called E1RNP, SSA, and SSB antibodies. Thyroid function is important, which is often a coexistent condition. In patients with scleroderma, they have abnormal thyroid function, either from Hashimoto's disease or a fibrotic process that affects the thyroid. And then if starting a biologic agent is anticipated, some of our patients do need biologics such as Rituxan or tocilizumab, which is Actemra, for treatment of lung disease or skin disease. In that case, it's important to screen for hepatitis B and C, and also for TB before initiating those therapies. So those are some screening blood tests that would be required at any stage when we consider starting a biologic agent. Autoantibodies in scleroderma, as I said, 90% of patients with scleroderma will have a positive anti-nuclear antibody. 100% of patients with lupus will have it, but also 90% of patients with scleroderma. So if a patient with Raynaud's does not have ANA, chance of having scleroderma as the cause of the Raynaud phenomenon is extremely low. And then we have these specific autoantibodies that you have heard about already. The 25% of patients will have anti-centromere antibody, which is associated with limited cutaneous systemic sclerosis or limited scleroderma, formerly CREST syndrome. And then we have another 20% will have SCL70 or topoisomerase 1 antibody, which is typically associated with diffuse scleroderma, but these patients are at a high risk of interstitial lung disease. And then another 20% will have RNA polymerase 3 antibody, also associated with diffuse scleroderma, but they are at a high risk of renal crisis or kidney failure, and less so with interstitial lung disease or pulmonary hypertension. So these two are associated with diffuse scleroderma, whereas anticentromere is associated with limited scleroderma. And then less commonly encountered antibodies, anti-THTO, anti-fibrillary, anti-PMSCL. These antibodies are mutually exclusive. So if you find one, there is no reason to keep looking for others. But if a patient clinically has all the features of scleroderma, but none of these antibodies, the commonly encountered ones, are present, then we should be looking for these less commonly encountered antibodies, THTO, fibrillary, and PMSCL. And then there are some patients with no antibody at all. So they have there's no question in our mind, they have scleroderma, but there is no antibody, including an ANA. It's a small subset of patients, but it does happen. So the diagnosis is, at the end of the day, the diagnosis is clinical. And then no scleroderma specific antibody, as I said, in some small group of patients. We discussed this already. Centromere antibodies tend to have mild disease, only involvement from elbows down, knees down, and they spare the trunk. 70 to 80% of patients with limited scleroderma will have this antibody. SCL70, about 30% of patients with diffuse scleroderma will have this antibody, and you will be alarmed that they have a high risk of interstitial lung disease. Anti-THTO antibody that behave like limited disease, so their skin involvement is similar to those with anti-centromere antibody, with fingers, hands, forearms, feet, legs, but they are at a high risk of pulmonary fibrosis, pulmonary hypertension, and overall the survival is worse compared to those with centromere antibodies. RNA polymerase 3, as I said, is associated with diffuse scleroderma and renal crisis. And then inflammatory markers can be normal in about 50% of patients. And these patients don't necessarily have to have a high sedimentation rate or a C-reactive protein. So this is a nice schematic showing the subsets of patients who have the diffuse disease phenotype, the SCL70 RNA polymerase, and sometimes U3-RNP patients have the diffuse disease phenotype. Similarly, these are the patients who have the limited disease phenotype, as I said earlier, anti-centromere, anti-THTO patients. And then there are some that have an overlap of scleroderma and myositis or muscle inflammation. And that typical example is anti-PMSCL antibody, anti-COO antibody, and sometimes there are some other patients who are not being discussed here have that subset, including some patients with no antibodies at all. This is an antibody, anti-U11, U12, or anti-RNPC. These patients are at a high risk of interstitial lung disease and major gastrointestinal problems. And similarly, we have patients who have anti-U3-RNP who have a high risk of interstitial, who have a high risk of cardiomyopathy or cardiac involvement, pulmonary hypertension, and muscle disease, U3-RNP antibody. So for most patients, the main antibodies to remember are SCL70, centromere, and RNA polymerase 3. So we will go over this quite fast because this was discussed at some detail by various speakers before. So initial evaluation should include a pulmonary function test and a high-resolution CT scan. In a pulmonary function test, we check the forced vital capacity and the carbon monoxide diffusion capacity or transfer factor. This was discussed by Dr. Volkmann yesterday. And then we have the high-resolution CT scan of the lungs, which is scanned without any iodine contrast, so people don't have to worry about iodine allergy. A 6-minute walk test is often ordered to evaluate the exercise tolerance in these patients, and then echocardiogram to overall function of the heart, and also estimate right ventricular systolic pressure, which would be a way to screen for pulmonary hypertension. So detection of scleroderma interstitial lung disease would require a pulmonary function test, as I said, where the two numbers that we are mostly interested in are the forced vital capacity and the DLCO. but also you are getting total lung capacity and forced expiratory volume in 1 second, which is helpful to diagnose obstructive rather than restrictive lung disease that some patients with scleroderma also have. But the two main numbers we are interested in are forced vital capacity and DLCO. Then we have the high resolution CT scan of the lung, which is the investigation of choice to screen for interstitial lung disease in scleroderma. In the past, bronchoscopy with bronchoalveolar lavage, but when a tube went into the lungs to wash out the lungs, and also an open lung biopsy, those were performed in the past, but now they have lost their popularity. Because they are invasive procedures, and two, they do not add any additional information. Bronchoscopy in a patient with scleroderma is only helpful when we are looking for another condition in the lungs, such as an infection or a cancer. But for evaluation of interstitial lung disease, bronchoscopy or open lung biopsy are not required anymore. So the functional evaluation of the lungs will be the pulmonary function test, and the structural evaluation of the lungs will be the high resolution CT scan of the lungs. For pulmonary function test, the spirometry, how is that performed? And the test takes about 30 to 45 minutes to complete. Here is what to expect during your spirometry test. You'll be seated upright in a chair, and a clip will be placed on your nose to keep you from breathing through your nose. Then, with a mouthpiece connected to the spirometer, you will be asked to take a deep breath in so that your lungs are completely filled with air, and then to breathe out as hard and as fast as you can for 6 to 8 seconds to completely empty as much of your lungs as possible until your lungs are emptied as much. You will be asked to repeat these steps at least 3 times to make sure that the test result is accurate. So this is basically what is happening. This trained nurse, or the respiratory technician rather, is watching and helping the patient during the test. The machine is recording the numbers here, and this is the mouthpiece that is put in the mouth. Sometimes you need a narrower mouthpiece in a scleroderma patient who have difficulty opening their mouth. The nose is actually blocked with a nose clip, and the patient is taking deep breath and blows as hard as possible into the mouthpiece for 6 to 8 seconds until the lungs are emptied as much as possible. The forced vital capacity, or FVC, is a maximum amount of air you can forcibly breathe out from your lungs after taking in a deep breath. It is about 80% of your total lung capacity, which is about 4.8 liters, because some air remains in your lungs even after you forcibly breathe out. So you cannot breathe out entirely all the air from your lungs. The normal value can range between 80 to 120% of predicted. So for every patient, based on their gender, age, and height, you get a predicted number. And the patient's scores, the patient's values are compared to what is predicted as a percentage. So normal values in healthy males 20 to 60 years of age is 4.5 to 3.5 liters, and this corresponding numbers in females is 3.25 to 2.5 liters. So when we are talking about reduced vital capacity, mild reduction of vital capacity is 70 to 80% of the predicted number. Moderate reduction is 50 to 70%, and severe reduction is less than 50%. So that would indicate quite severe restrictive lung disease. So the gas transfer test is the other test, which is called carbon monoxide diffusion capacity, that estimates how well your lungs work to transfer oxygen from the air that you breathe in into the bloodstream. It is a test which determines how well your lungs can exchange gases, mostly oxygen and carbon dioxide, and can help in the diagnosis of different types of scleroderma associated lung disease. And it can be impaired in both interstitial lung disease and in pulmonary hypertension. In interstitial lung disease, both the vital capacity and the DLCO goes down. whereas in pulmonary arterial hypertension, there's a disproportionate drop in the DLCO with relatively preserved vital capacity. It uses a small but safe amount of carbon monoxide and sees how long it takes to disappear into the blood during a 10-second breath hold. So the normal DLCO is more than 75 to 140% of predicted. Mild reduction is 60 to 75%, moderate reduction 40 to 60%, and severe reduction is less than 40%. So this is called the single breath DLCO, or carbon monoxide diffusion capacity. So these are the steps. You're initially asked to take normal breaths. Then you will be exhaling, blowing out all the air from your lungs after a few normal breaths. And then you are then asked to rapidly inhale the test gas up to vital capacity. If you see this, the amount of air that you can inhale, take in after you completely breathe out, is called the vital capacity. And that's what is being recorded. And then your lung is filled up with the test gas when you take a full lung full of air. And the test gas contains 0.3% carbon monoxide. That's why it's called carbon monoxide diffusion capacity. There is a tracer gas, which is an inert gas like helium or methane or neon, 21% oxygen. You are then asked to hold your breath for 10 seconds. So that's the important part. But sometimes you may have difficulty holding it because of your breathing difficulty. And at total lung capacity, you're holding your breath. Then you breathe out completely. The blown out gas is collected for analysis of carbon monoxide and tracer concentrations. And usually you have to repeat this test 2 to 3 attempts to get an average. And that's the carbon monoxide diffusion capacity number that will be provided. So this is how this procedure is being done. Here, carbon monoxide diffusion capacity, single breath DLCO. And this is basically the nose clip, and you are actually blowing out and then blowing in through this tube that is connected here, which has the test gas. So these are the different phases of it. This is the normal respiration. Then you blow out, then you take a deep breath in, and then you're holding your breath here, and then you're expiring. The first part of what you're blowing out is called the dead space or washout. And this is the sample that is being collected. And this is the effective breath holding duration that is being that is being recorded here. Bottom line is, this is a test to evaluate your gas exchange in the lungs, both oxygen and carbon dioxide. The high resolution CT scan of the lungs is the gold standard test now to evaluate interstitial lung disease. It's a method of structural evaluation of the lungs. It does not require iodinated contrast, as I said. It's more precise than a chest X-ray in the diagnosis and monitoring of the lung disease and the airways. HRCT scan of the lungs is useful and is a test of choice for detection of scleroderma ILD. It gives us information about the nature and extent of interstitial lung disease. So this is what normal lung looks like. We have seen a lot of this throughout this conference. So the black is normal lung, the heart in the center, the aorta here. And this is what happens in interstitial lung disease. A lot of inflammation and scarring is happening in the periphery of the lungs. So what is useful when we do a high resolution CT scan, we can get an idea about the nature of the interstitial lung disease. This appearance is called ground glass opacification. You cannot see through it. And that is typically associated with this pathologic pattern called non-specific interstitial pneumonia. This is the kind of lung disease that tends to respond to immunomodulatory therapy more so than the extensive scarring kind that happens less commonly in scleroderma. So under the microscope, this is what the appearance is. So the lung tissue is uniformly affected, and there's inflammatory cells and some fibrosis that happens throughout the lungs. This is in contrast to the other kind of lung disease, which is called usual interstitial pneumonia, where there's extensive scarring, coarse network without much inflammation. This is all scar tissue formation in the lungs. This tends to happen later in the course. If the other pattern is not treated, there's extensive scarring that develops over time. And that is called usual interstitial pneumonia pattern, which is also seen in the other condition called idiopathic pulmonary fibrosis. And here you see areas of normal lung that is interspersed with areas of scarred up lungs with minimal inflammation. So that was the assessment of the type of lung disease, but also the extent of lung disease can be evaluated. So the quantification of extent of fibrosis on the high resolution CT scan can be evaluated using some computer algorithms. And then that's been divided into both the limited and the extensive lung disease. Depends on the extent of involvement of each lung. So when the involvement of the lung in the form of fibrosis or inflammation is less than 10% based on this computer algorithm, it is called limited lung disease. Whereas if it is more than 30%, it is called extensive lung disease. So the limited lung disease patients, as you heard earlier, are the ones who have mild and often tends to be non-progressive lung disease, whereas those who have much more severe, extensive involvement of the lungs, the other ones not only have worse lung disease to start with, but also tend to progress. So it gives us prognostic information. If the involvement of the lungs is in between 10 to 30% on the quantitative CT scan, then we use the pulmonary function test to put them in different categories. In those patients with 10 to 30% involvement, if the vital capacity is more than 70%, we put them into limited lung disease, whereas if it's less than 70%, that means there's more involvement of the lungs, then we put them also in the extensive lung disease category. Pulmonary hypertension that you also heard about earlier, and you will be hearing probably from Dr. Hyland later on. All scleroderma pulmonary hypertension patients should be referred to a specialized pulmonary hypertension center for evaluation and management. So echocardiogram needs to be done upfront, and then at regular intervals thereafter. It's a screening test for pulmonary hypertension, normal echo, and other tests if necessary, including a stress echo, and then follow up at 1 year, but more frequently if necessary. But patients who have a normal echo upfront can be just monitored with an annual echo, sometimes more frequently. However, if there's suggestion of pulmonary hypertension that I'm going to talk about in the next slide, then they need to get these other tests done: pulmonary function, an X-ray, a VQ scan to look for clots in the lungs, a CAT scan to look for interstitial lung disease, which can also be associated with pulmonary hypertension. Eventually, a right heart cath will be necessary for confirmation of diagnosis, and then targeted treatment would be offered. So patients newly diagnosed with scleroderma need a baseline echocardiogram and a pulmonary function test. And then patients with existing diagnosis, every 3 to 6 months, at least in the first 5 years, they need every 3 to 6 monthly pulmonary function test. And at frequent intervals, less than in about every 6 months at least, an echocardiogram needs to be considered upfront. However, keep in mind, patients do develop pulmonary hypertension sometimes later in the course of their disease, so that initial screening will be followed by regular echocardiograms, at least annually, to follow patients who might develop pulmonary hypertension later in the course of their disease. These are the findings. This is a 4-chamber view of the heart. Increased right ventricular systolic pressure, which is an estimate that can be calculated from the tricuspid regurgitation jet. that you heard from Dr. Silver yesterday. So this is the fourth chamber of the heart, the right ventricle, the right atrium, the left ventricle, and the left atrium. Normally, the left ventricle should be the larger chamber. Here you can see the right ventricle is larger than the left. Similarly, the right atrium is larger than the left atrium, which should not be happening. The interventricular septum, which is the partition, should be bulging towards the right ventricle, but if the pressure builds up, then you will be actually noticing that the septum is bulging towards the left ventricle, leading to reduction in the size of the left ventricular chamber, which can be the cause of syncopal episodes because your cardiac output is reduced and there's not enough blood going to the brain. So the right atrial and ventricular hypertrophy, as I said earlier, flattening of the septum, small LV dimension, as we discussed, will be seen. This is a 6-minute walk test. Here, the distance walked in meters, blood pressure, heart rate, oxygen saturation, and shortness of breath scores are recorded when a patient is asked to walk as far as possible in a 6-minute period without running or jogging. And this is an indirect way of evaluating the heart and the lung function and would be helpful to evaluate that in patients with either interstitial lung disease or pulmonary hypertension. Keep in mind, patients with scleroderma can be slowing down from arthritis of the lower extremities, poor circulation, and we have to keep that in mind. So the 6-minute walk test gives us information about prognosis in patients with pulmonary hypertension and interstitial lung disease. This study that was published in 2000, patients walking less than 332 meters had a significantly lower survival rate compared to those walking further. So this is the quick bedside evaluation of breathing in patients with scleroderma. So this is the right heart cath, which is a procedure where a catheter is introduced into the right atrium. And this is a test that is done to confirm a diagnosis of pulmonary hypertension. The echo would just be a screening test. The pulmonary hypertension confirmation can only happen through a right heart cath. So the transducer, which is this yellow sensor here at the end of this catheter, which can be introduced either through the neck, through the elbow, or through the groin, gets into the right side of the heart and the right ventricle, and then it goes into the into the pulmonary artery, and eventually it wedges. When the balloon is inflated, that's called the wedge pressure, which is a reflection of the pressure on the left side of the heart that is being recorded. So these are the different pressure tracings as this catheter is traversing these chambers of the heart. And that is basically what a right heart catheterization is. So basically the numbers we are looking for: increased mean pulmonary artery pressure, more than 20 millimeters mercury. That's the new definition of pulmonary hypertension. Normal pulmonary capillary wedge pressure, which is the pressure that I showed you when the catheter wedges with the balloon inflated. That is indicative that the left side of the heart is working normally. And pulmonary vascular resistance is also measured in Wood units, and it has to be more than 3 Wood units. So a combination of these three establishes a diagnosis of pulmonary hypertension. Subsequent evaluation, monitoring, and follow-up. So periodic blood counts with or without any medications that might be affecting blood counts. Patients need to get a periodic CBC differential count, metabolic panel, urine analysis every 3 to 6 months, pulmonary function tests every 4 to 6 months for the newly diagnosed, and more frequently if interstitial lung disease is suspected or diagnosed. Echocardiogram at the same time also needs to be repeated in the beginning every 6 to 12 months, and more frequently if pulmonary hypertension is suspected. So the diagnosis is confirmed with a right heart cath, but the monitoring over time can be done with an echocardiogram. A high-resolution CT scan of the lungs is done upfront for every patient, and then it can be repeated in future if necessary, based on the diagnosis of established interstitial lung disease. And if there's worsening of pulmonary function numbers, a CAT scan can be repeated annually and thereafter as needed. And a right heart cath, which is an invasive procedure, is done to establish a diagnosis of pulmonary hypertension initially, and then as necessary, if patients are not adequately responding to their treatment. Briefly, I'm going to talk about the gastrointestinal complications of scleroderma. Esophagus is the most common site of GI symptoms. Dysphagia or swallowing difficulty, which is a result of dysmotility versus structural abnormalities. Acid reflux disease, esophageal narrowing from scarring or strictures from chronic acid reflux that causes ulcerative esophagitis that can cause scarring and actual narrowing of the esophagus. Pill esophagitis, sometimes pills that patients are swallowing with reduced motility can get stuck in the esophagus, cause irritation and pill esophagitis. And then Barrett's esophagus is a result of chronic acid reflux, changes in the lining of the esophagus from one kind of epithelium to a different kind, which can be precancerous, leading to a risk of adenocarcinoma or esophageal cancer of this kind. So how do we diagnose esophageal problems? Esophageal manometry, which is where we are measuring the pressure. Barium swallow, there are several varieties. So you get a barium liquid, the patient is swallowing, and pictures or x-rays are taken at different phases. Bravo, which is a monitoring of the pH, which is reduced if you are refluxing acid. You have a lower pH in the esophagus, and that can be recorded. An upper GI endoscopy to look at structural abnormalities, even take biopsies, which is called an EGD or esophagogastroduodenoscopy, which is a mouthful. Endoscopic ultrasound, less commonly done. So this is esophageal manometry. As you can see on the y-axis, you see the length along the esophagus. So this is a normal esophageal manometry. So a few things to understand here. So the x-axis is you're looking at the time and then the color coding here indicates the pressure. So in a normal swallowing phase, you can see the red is a higher pressure based on this pressure gauge at the bottom. And this is how the contraction happens in the esophagus as the food is going down. So that's called a normal manometry. So this is how it is being done. So this tube is being inserted through the nose and it is going down the esophagus, and the pressure is being recorded at different phases of this. It goes all the way down and it is being pulled out slowly. This is a normal manometry, as you can see on the left side. On the right side, you can see there is no contraction in this particular patient with dysmotility of the esophagus. This is barium swallow compared with this other condition where the lower end of the esophagus is narrowed, called achalasia. But what we're mostly interested in is this wide open esophagus with no peristalsis, and the barium is filling up. This is upper GI endoscopy where the scope is entered and you can actually take a good look inside the stomach. This is the light source. You can even obtain biopsies from that stomach. And this is what the upper GI endoscope looks like. And what you can see in the duodenum, which is the part of the gut after the stomach, you can see an ulcer here in the duodenum, which is here. And on here, there is an ulcer in the stomach, which all can be picked up on an upper GI endoscopy. And these are sometimes bleeding vessels that are seen in patients with scleroderma, which are telangiectasias that can be in the stomach or even in the small intestine. And you can see them. They can be a source of blood loss, and they can be cauterized during the procedure. This is what we talked about earlier, watermelon stomach. As you can see, the stripes of the watermelon. And that can also be a source of blood loss in patients with scleroderma. This is a delayed gastric emptying study where you are putting either radio level solid or semi-solid meal and just detect how long it takes for the stomach to empty. Small bowel issues could be malabsorption, small intestinal overgrowth, wide mouth divertically, intestinal dysmotility. So chronic intestinal pseudo-obstruction. So this is called a smart pill that can be swallowed, and it can go down the entire GI tract, stomach, small intestine, and take pictures and measure pressures and find pathology. It can eventually come out through the anal orifice, and all those recorded photos and the pressures and everything can be collected. Colon and anorectal problems could be constipation, less than 2 spontaneous stools a week, diarrhea, usually is a symptom of small intestinal bacterial overgrowth, fecal incontinence, rectal prolapse. These are some of the distal intestinal involvement manifestations of the colon or the large bowel. So evaluation would be colonoscopy, flexible sigmoidoscopy, colonic scintigraphy, which is a radio label tracer that is going down, and it just detects how long it takes for the colon to empty. Wireless motility capsules, and then X-rays can be also obtained for the anus, and it's called a difficogram. For those patients who are having problems with fecal incontinence, this is a dynamic fluoroscopic procedure for evaluation of pelvic floor anorectal muscle contractions. Anorectal manometry, similar to upper GI, like the esophageal manometry, anorectal manometry can measure pressures in the rectum, endoanal ultrasound, pelvic MRI, surface EMG. So in summary, there is no single test for scleroderma. It is a clinical diagnosis that requires a thorough history and physical exam. Your rheumatologist will start by asking questions about symptoms and obtain a detailed medical history. The rheumatologist will also, with an expertise in scleroderma, will perform a skin score and a Nailfold capillaroscopy. Then various blood, urine, and other tests will be performed, as we discussed earlier. And then these are also periodically repeated to follow course of disease. So the action items: all patients should be referred to a specialized scleroderma center for evaluation and management. Please discuss your current new symptoms with your rheumatologist. And then understand the rationale for testing and the complexities of these testings. Please request your rheumatologist to order all necessary tests initially at the point of diagnosis and then at specified intervals, as we discussed. And also request your rheumatologist to explain your test results in layman's terms. An earlier diagnosis leads to earlier treatment. It was a whirlwind tour. Sorry I took the whole hour. So good luck and best wishes. Thank you for inviting me. I can take questions if I have time. I understand there's a break, so if there's time, I can answer some questions. That's a great question. Given that 50% of patients have normal ESR and CRP, are there better markers for scleroderma activity out there? So we discussed these. So basically, we do the skin score. We look at other symptoms in the patients. The activity can be measured by, doing a modified Rodnan skin score. We also evaluate the lung function with a high-resolution CT scan, and also do the pulmonary function test. Similarly, we do periodic echocardiograms. So the activity of scleroderma is actually a combination of various organ systems that can be affected, which is very different from patient to patient. Can you have anti-centromere and SCL70? It's usually they're mutually exclusive. So if you find one antibody, you don't usually get another. I have a few patients who have more than one, but typically when patient has centromere, as we heard, it tends to be with limited cutaneous disease, whereas SCL70 with diffuse disease. So if you have one antibody, it's best not to keep looking for others. Try to recognize, this is my disease, This is my antibody, and these are the organ systems that I need to be focusing on in future. These are the likely manifestations of the disease that I might encounter in future. Do antibodies influence GI tests? As recommended, done when first diagnosed. For example, ACA and RNPC3, I think you meant. So yes, patients with certain antibodies may have a different pathophysiologic basis of their gut involvement. So especially the dysmotility, now as you heard that excellent talk from Dr. Walkman yesterday with RNPC3 antibodies can be associated with antibodies forming in the gut that are causing the pathophysiologic explanation for the dysmotility as opposed to fibrosis and circulatory problems. It's important to know that because there might be a role for immunomodulatory therapy in such patients as opposed to just symptomatic treatment of dysmotility and bacterial overgrowth. I read that RBC clumping and high blood viscosity occur with scleroderma. Are there tests for this? So you can order a plasma viscosity test. It's not a routine test, but it can be ordered. And the RBC clumping can be picked up on a peripheral smear. So when patients are ordered as a complete blood count with complete metabolic panel, the complete blood count with differential peripheral smear is created, and the clumped RBCs can be seen there. And that usually is a manifestation of high gamma globulin levels, as you see in conditions like multiple myeloma. I do not see any other questions so far. So thank you everybody for attending. Sorry I went a little beyond. I had a lot to cover, but hopefully the information that I provided was useful, and hopefully you can use some of this information in future. And these slides, I understand, will be available. The presentation will be available for the next 2 months. Thank you again. Thanks for inviting me.